Thank you, Dr. Masters. We're going to bring on Dr. Ken Ligner. Ken is from Westchester County in New York, and he has been making quite a precise study of persistent disease in spite of conventional and at times greater than conventional therapy. And he's going to give us a sense of this. Ken?
Thanks very much, Paul. I want to, does this reach here? Can this be lengthened? Oh, okay.
Could someone give us an overhead light, please?
There. Stick that in your pocket. Okay. Now, angle. Okay, can everybody hear me? Okay. I want to thank the Forschners and the Lyme Disease Foundation for inviting me to talk. And I want to let everybody know what a pleasure it is to be here. I feel very honored to be here, and I always find it a pleasure to share this event with other people who are contributing to our understanding of Lyme disease. The title of my talk is Chronic Persistent Infection in Lyme Disease, and also Chronic Persistent Denial of Chronic Persistent Infection in Lyme Disease. And I prepared well in advance for this, and I sort of got carried away and prepared, I guess, about a 6-page outline, which I've distributed to people. And by the way, does everybody have a copy of that? Okay, and also there is a companion compilation of some materials relating to two particular patients. And let me, I have an additional supply of those. Just pass these out, and there's more up front for anybody who wants it. Okay, as far as my... There are plenty up on the stage afterwards. If you don't get them, you can come up and pick them up. As far as my outline, it's 6 pages, and I think it's kind of silly for me to stand up here and read to you what's on the outline, although I would encourage you all to take the time to read it because I think you'll find it worthwhile. The reason that I produced the outline was I'm a firm believer that if you analyze a problem thoroughly and carefully, and also if you make what is tacit explicit, that will help overcome the resistance to a problem. And I think there is a problem here. I think there already is adequate documentation in the peer-reviewed literature demonstrating the survival of Borrelia burgdorferi despite aggressive antibiotic treatment. I don't think it's a controversial issue anymore. It's in the literature. So that's not the problem anymore. The problem is chronic persistent denial of chronic persistent infection. That is what the problem is. And I think if you read the outline, a lot of things are laid out there, and I think you'll find it interesting. Now, what I would like to do, however, is instead of reading the outline to you, I thought what I'd like to do today is to share my experience with a couple of patients of mine. And, you know, there's been a lot of talk lately about overdiagnosis of Lyme disease, overdiagnosis and overtreatment of Lyme disease. And I thought I'd share with you two of my patients who have been allegedly misdiagnosed or overdiagnosed or overtreated, and let you go through the reasoning processes that I went through and also show you some of the evidence that I think demonstrates the errors that some of my colleagues have made in making snap judgments about who has Lyme disease and who may have a chronic persistent infection. One of these patients is a young man who's a deer hunter, has had documented deer tick attachments, and in fact got treated basically prophylactically for deer tick bite a couple of years ago. And along with that treatment, or shortly following the treatment, he began to become symptomatic. My own suspicion, although I can't really prove it, is that he probably had other unsuspected deer tick attachments and perhaps might have been sick from Lyme disease in a latent way before he even recognized that particular deer tick attachment. Anyway, he went on to have a fairly characteristic illness, although I don't think he ever had erythema migrans, but he did prove to be seropositive, repeatedly seropositive, was ill with a fairly compatible illness, was treated by another physician with a variety of antibiotics, including oral antibiotics and at least 2 courses of ceftriaxone. One, I believe, was a 2-week course, and the second time he was retreated for a 4-week course. And he definitely responded to treatment. He definitely improved. In fact, was well for quite some period of time, and then relapsed. That was about the time that he consulted me, because he had recurrent symptoms. At about the time he came to see me, other physicians who had been involved in his case had come to the conclusion that he had, quote, post-Lyme syndrome, and really did not want to treat him any further. And in fact, he went to one of the major Lyme academic centers. I haven't used these overheads before, so let me see if I'm... Oh, there you go. That's great. And I thought it might be best to remove all identifying data, not only as far as the patient, but also as far as the particular Lyme center and the physician who reviewed his case. I'll just leave this up here for a minute. Maybe you can just prove that you have the same thing if you've gotten the originals. But the bottom line was that the physician who saw him felt that his symptoms at this point were, rather vague and nonspecific, and even went on to make the following suggestion that you'll see the bottom paragraph that symptoms are very nonspecific, and when a patient presents with recurrent symptoms, one way you can deal with it is to think that perhaps they, really you have Lyme, and the other is to say, well, this doesn't fit our preconception of how Lyme should behave, therefore it's not Lyme. So that's what was done. I quote, I think the possibility that he has a false positive serology certainly exists. I would like to do both the repeat ELISA and also check a Western blot test to see whether he is making Lyme disease-specific bands. And in fact, the patient did have a Western blot at this medical center and also through my office, and through both places, the Western blot was negative. And that was used as a very potent weapon against the patient because, for example, the third-party administrator that administered this patient's company's benefits used that negative Western blot and also this consultation from this major academic Lyme center to state that likely the patient didn't have Lyme disease to begin with, and in any case, he absolutely and flatly refused any further authorization for further antibiotic treatment, specifically intravenous antibiotic treatment, because that's usually when third-party administrators get involved because of the expense. In any case, it was recommended that further antibiotics be stopped and the patient just be observed. I evaluated the patient, and because of his ongoing symptomatology and history and the positive ELISA and his past response to antibiotic treatment, I strongly suspected that the patient did have a chronic persisting infection. I had many lengthy and frustrating conversations with the person's third-party administrator, and I wish I could share with you the details of those conversations, but I really can't right now. But it's quite a trip dealing with some of these physicians who are acting as third-party administrators. I had suggested to the patient that it would be highly desirable for him to undergo lumbar puncture. The patient wasn't really thrilled about that, but finally, because the third-party administrator flatly refused any further treatment, the patient acquiesced to undergo lumbar puncture. And in fact, I referred the patient to Dr. Coyle, and the lumbar puncture demonstrated a number of things. It demonstrated, first of all, getting back to some basic things, I don't know if this projects too well, but the patient had a lymphocytic pleocytosis. He had 8 white cells per high power field, and he had an elevated CSF protein, i.e. he had evidence of a chronic meningitis. Furthermore, you can see down here that on routine Lyme serology, 0.472, the cutoff being 0.138, he was strongly reactive on a Lyme ELISA. But more interestingly, thanks to the excellent work that Dr. Coyle is doing, her assays demonstrated the presence of Borrelia burgdorferi specific immune complexes, IgG, in the spinal fluid. His reading is 0.060 with a cutoff of 0.055. And furthermore, there was strong evidence of, on ELISA antigen capture, the presence of outer surface protein A antigen, 0.086 with a cutoff of 0.06. So here's a patient that an academic expert, happened to be a rheumatologist, felt probably either didn't have Lyme at all or had a post-Lyme syndrome, and yet we were able to produce very good evidence of chronic persisting infection. You would have thought, or I would have thought, that armed with this evidence that we would have had very little difficulty getting the agreement of a third-party administrator that this patient was in need of further parenteral treatment. But that was not the case. The third-party administrator had a very long-winded discussion with me and was trying to convince me that what this patient really should be treated with was several months of oral tetracycline. He was telling me that there was new data that is in research showing that oral tetracycline for a 2 or 3 month course is curative. And I said, is that so? And he said, yes. And I said to him, I do sometimes use the tetracyclines. I tend to use minocycline because of its superior pharmacokinetics and penetration into the central nervous system. But there's no evidence whatever that oral tetracycline produces adequate central nervous system levels. And he said, well, that's really not that's really inconsequential. It really doesn't matter. And I said, well, why would that be inconsequential in a patient who shows evidence of an active central nervous system infection? Finally, the third-party administrator basically acquiesced and permitted us to start retreating the patient with intravenous cefotaxime, which he hadn't been treated with before. My own preference was to treat the patient with perhaps a short course of daily cefotaxime and then switch him over to a course of pulse cefotaxime, which I have found to be very helpful and useful in patients with chronic infection. The third-party administrator flatly refused to allow that, saying that that's an unproven therapy. That's anecdotal. There are a couple of points that I'd like to, and by the way, the patient is now on intravenous cefotaxime, and I think the patient has come to the conclusion that whether or not his employer will pay for pulse therapy after we complete the 28 days that has been authorized by the third-party administrator, the patient, I think, is going to just pay privately if he needs to, and deal with the insurance company later on, perhaps. There are a number of things that flow out of this case illustration. One is that third-party administrators that are supposed to be strictly administering benefits actually, as in this case, are determining treatment. They are actually practicing medicine despite the fact that they have absolutely no professional relationship with the patient. They have never examined the patient. They have never taken a history from the patient, and they have no professional responsibility to the patient, and yet they are determining treatment. Also, I think there is a lack of due process for the patient. The third-party administrator was insisting that he get additional opinions from infectious disease people, this person, that person, and yet the third-party administrator would not even divulge to me or to the patient who these sources of expert opinion that they were relying upon to make their judgment was. Another thing, what if this patient hadn't come to me? What if this patient, and I know that in addition to this patient, there are many patients in his situation. Maybe they don't have a physician who has a bent for clinical research. Maybe he doesn't have a physician who is fortunate to be able to collaborate with people who are doing cutting-edge research work. Maybe he doesn't have a physician who is willing to put up with the nonsense of dealing with third-party administrators. Maybe he has a patient who doesn't want to undergo a lumbar puncture, and not everybody wants to undergo a lumbar puncture. Does that mean that those patients are any less sick than this patient? No. What I would like to suggest is that major injustices are being perpetrated against patients with Lyme disease. Okay. I want to go on to another illustration. This is a case of a patient who is a farmer from upstate New York in an area where until recently there wasn't supposed to be any Lyme disease. In fact, one of my colleagues up in upstate New York tells me that now the New York State is declaring that central New York is an endemic area for Lyme. So that's going to be helping a lot of people because now it's okay to have Lyme disease up there. But anyway, he's a farmer and also has worked part-time for a county highway department in upstate county. And while working, he sustained a bite. He did not see what did him. He can't swear that it was a tick, and he didn't have an erythema migrans rash, but he definitely had some type of a bite. And following that, he became ill with an illness with multi-system symptomatology and developed Bell's palsy. Early in the course of his illness, he had either a borderline or just a cusp off of positive Lyme serology by a particular laboratory. And after that, he was seronegative on routine tests. He saw me, he was referred to me for consultation by his local physician, and I felt clinically that the diagnosis was Lyme disease. He was treated by his local physician with a variety of antibiotics, oral and then intravenous antibiotics, which definitely helped him. He improved a great deal, but then he has had a tendency to relapse. And that was fine, and the diagnosis of Lyme was accepted by his insurance company, which is it's a company that insures the county highway department. I think it's a self-insured county, but it's administered by an insurance company. Until his illness, kept being, troublesome, intractable, meddlesome, costly. And then the insurance company decided to, our solution to this is let's have the case reviewed by an expert consultant. So I have for you a letter from that expert consultant who also is involved in a major way in a major East Coast academic Lyme center. And this was the letter that was sent to the insurance company. I'll just leave it up there for a bit, so you can look at it. And you have copies of this before you. But basically, it contests the diagnosis of Lyme disease. Mind you, as in other cases, based strictly on a review of medical records, and I might add, I don't even think the complete medical record. I think the academic expert was perhaps fooled himself by being supplied with only a portion of the clinical record. However, this person didn't seem to go to any length or any trouble to assure himself that he had, in fact, reviewed the complete clinical record. For example, I was never queried, or no copies of any records from my office were ever requested from this person. But that didn't stop him from saying, in the bottom line here, he has had an extraordinary number of laboratory tests to try to substantiate the diagnosis of Lyme disease, all of which, in my opinion, have been negative. In addition, it is not surprising that he has failed to respond to therapy for a disease which he apparently does not have. Thank you for allowing me to help you in this case. If there are any further questions, please do not hesitate to call me. I felt obliged to respond to that for a lot of reasons. One, this patient is a salt of the earth type of person. He's a farmer. He's not a wealthy person. He doesn't have means. This man is dependent on his health insurance benefits through workers' comp for all of his health insurance claims regarding Lyme disease, and also for his disability. So if this stood unchallenged and was successful, this man would really be SOL, as they say. This is my letter in response, and I go through the story and present the data that I have available, including the fact that he had a Western blot that was highly suspicious for Lyme disease with, I think, 34, 75, and 41 kilodalton bands. And then a more recent Western blot showed a 39 and 41 kilodalton band. I think most people in this room are aware that the 39 kVA band, many people feel, is highly specific for Lyme disease. In addition, we had a bunch of other things, including a polyclonal IgM elevation, which would imply organic disease. And also, recently, it was shown to have IgM anticardiolipin antibodies, which are also associated with neurologic Lyme disease. And also, which may explain his relapsing course, perhaps. He happens to be HLA-DR3 allele positive. And I just go on to argue the case. I don't want to belabor the point, but just to also, point out is more than likely, with another physician, this letter from this academic Lyme expert probably would have prevailed. It was very time-consuming for me to prepare a response, but I did it on the patient's behalf, but not only on the patient's behalf, but also on my own behalf, because the implication of this academic Lyme expert is that I, Kenneth Liebner, am misdiagnosing patients, and that is a professional insult to me. So I felt that I had to defend myself. In any case, this patient went on, also agreed to see Dr. Coyle at his own expense, and had a spinal tap, and also had some blood work on serum. And in that box, you can see that Dr. Coyle was able to demonstrate in the serum the presence of Borrelia-specific immune complexes, both IgG and particularly IgM. The IgM, in fact, was higher than the IgG. Curiously, in this particular patient who had neurologic symptoms, his spinal fluid really didn't show anything, neither OST-A nor immune complexes. But as Dr. Schutzer suggested, the presence of immune complexes in the serum is very suggestive of active infection. A couple of points that these cases bring to mind is that it just makes you wonder These are cases that have been looked at in detail. I tend to be very rigorous in my evaluation of patients. But there may be many other patients who are being billed as being overdiagnosed as having Lyme disease. And I can't speak for Dr. Steer's patients. Those are his patients that he reported in the JAMA article. But I suspect that if those patients were carefully scrutinized in the way that these patients were scrutinized, that many of them who are being called non-Lyme, fibromyalgia, chronic fatigue syndrome, it would be highly likely that many of those patients indeed do have Lyme disease. Well, this question of chronic persisting infection and what's Lyme and what's not Lyme, obviously it is a scientific issue, but it is not just a scientific issue. It is also becoming a political issue that is going to be decided in the political arena, and it also is an issue that increasingly is going to be decided in the courts. There's also been a lot of talk about, we have to be scientific. We have to be scientific, and I think indeed one should try to be scientific. And I think with some of the newer kinds of direct antigen detection methods that are available, it will be possible to put this on a more scientific basis so that we have objective markers and it's not just a clinical call, which is difficult, and in which there can be room for controversy. Okay. One of my mentors, do I absolutely have to stop? Okay. Well, I guess I better cut it short then. Thank you for your attention.
And I really didn't intend to give you the hook so briskly. We are running late. We're 15 minutes over the schedule. The last talk of the day will not be given today because we are running late, and hopefully it will be given tomorrow morning by Dr. Katza. And what we're up for now is the public forum, which traditionally has been a very interactive part of these conferences, and I think educational to both the scientists, physicians, and the lay. We're going to hold this in approximately 10 minutes. I ask that all of the presenters, both from today and from tomorrow's presenters that are here today, stay here and come forward, and we're going to have the presenters up on the stage. And for the remainder of the folks that wish to participate in the public forum to come forward so that we can have it a little more intimate. We will not have an overview. Dr. Katzel has that responsibility simply so that we can get on to the interaction, questions and answers. I think you've heard enough when it comes to a sense of this disease that we probably do not need an overview. So if we take about a 10-minute break, we'll get back together by 17:45.
New wrinkle. Yeah. There's a picture, I tell you. That's the curious thing, I get it though. Yeah, I like to... There's one pretty good picture of the three of them together. Did you see that one? Pearson, Coachman, and Thomas. Okay, we're going to start the public forum right now. And the only rule tonight is that if you're sitting beyond 10 rows, we're not going to call on you. So we want everybody to move up a little closer. You've got a panel of very distinguished people here. Let's get close and take advantage of it. Okay, what we'll do is, instead of having an overall view of Lyme disease, I think we all have a good feeling for what's going on. I think we'll just open the floor for discussion and for questions. What I would ask you to do when you ask a question is to stand up and please talk loud. You can either go to the microphone or just yell it out real loud. And please tell us who you are. Give us your name and where you come from. I'll start the questions. I'd like to start with asking one of the pediatricians. I see a lot of patients that have been on antibiotics for a long time, and I'm sure you do too. What's the incidence of Clostridium difficile diarrhea that you see? And do you see an increased incidence in children as opposed to adults? We only have one mic, so we're going to have to share it.
I've seen about 2 cases of Clostridium difficile associated antibiotic diarrhea/colitis out of about 25 to 30 patients that I've seen in 6 months at Jersey Shore Medical Center. Definitely higher incidence in antibiotic patients who've been on long-term antibiotics. Extremely responsive to vancomycin. I haven't used Flagyl. I've used vancomycin for pediatrics. I use about 250 milligrams 4 times a day for 10 days. Then I reculture them after they've been off antibiotics for about a week to make sure that the toxin which we have found in the stool is gone. It's gone, and in those 2 cases have not recurred once they've been started back on antibiotics.
Maybe you can explain a little bit what it is, and what antibiotics are you seeing it most frequently with?
Okay, in the gastrointestinal tract, we have a mixture of many different bacteria. E. coli, Clostridium happens to be a normal intestinal flora. It's there in harmony with E. coli and many other bacteria. When you get put on antibiotics, the antibiotics will kill off the E. coli and the other bacteria preferentially, leaving the Clostridium difficile bacteria to overgrow and fill in the place where the E. coli was. The Clostridium difficile bacteria itself doesn't do harm. It's a toxin that it elicits. This Clostridium difficile toxin will perpetuate diarrhea. I've also seen Clostridium difficile toxin in patients who are not on antibiotics who've just had diarrhea from a viral source. So it's not only antibiotics. Any change in flora in the gastrointestinal tract, like chronic diarrhea and the use of antibiotics, can cause the Clostridium difficile, and it's the toxin that they produce that leads to perpetuation of the diarrhea. And the vancomycin is an antibiotic that's not absorbed into the blood. When you take it orally, it works directly on the Clostridium difficile infection, and they're able to get the other bacteria to grow back and keep it in check.
So the preferred route is oral rather than IV?
The preferred route for vancomycin to treat Clostridium difficile toxin diarrhea would be the oral route, not IV. The IV would have no effect on the gastrointestinal tract.
Same thing for metronidazole?
Same thing for Flagyl, metronidazole.
Thank you.
Thank you.
Yes, you had your hand up first. No, the lady behind you. We can't hear you up there. You got to scream it or go to the mic. Please. Anybody got a loud question before she gets there? Yes.
I don't have a question.
Your name, please.
My name is Stephen Melcher. I was founder of what's known as Lyme Early Outreach, founded in 1987. Located in a town called Madison, Long Island. Last year I had the opportunity to address the people very briefly. I'd just like to once again reemphasize the thanks on behalf of all Lyme victims of Long Island and elsewhere. I produced a 1-hour TV show every month and been doing so for almost a year on cable, and if it wasn't for the information that you people are disseminating to me, I don't know whether the news would have gotten out to the people of Long Island and the New York area. And I just want to thank you, don't give up, keep up the good work, and God bless you.
We need to thank you. Thank you. Yes, go ahead.
Hi, my name is Cindy Bernard. I'm from Livingston, New Jersey. My question is for the whole panel, whoever wants to answer it. How different, if any, is the Lyme disease found in Europe versus the Lyme disease found in the U.S.? If different strands, do they differ with the symptoms and treatments, and are they using different drugs in Europe?
Any volunteers? Dr. Lavoie. Oh, you had your hand up in the air. I thought you were volunteering. Anybody else?
I'm not sure that I understood all your questions. Was number one, are there different strains in Europe?
Then they're found in the U.S.
Yes, the answer is yes. They have, in the last 2-3 years, they have found that genetically different strains of Borrelia burgdorferi do exist in Europe, and as a result have already given these spirochetes different names. One is Borrelia garinii, and the other is VS462, I think. 461, I'm sorry. So these are different, genetically different strains. Whether or not they do produce clinical manifestations different from those in the United States is being investigated. They are using in Europe just about the same antibiotics as we are using in this country, as far as I know.
Okay, thank you.
Does that answer your question?
Yes, you did. Thanks.
Yes. Can you tell us your name?
My name is Julia Urban, and I live in Jackson Heights, New York, and I'm a member of
We'll repeat it. This is as far as it goes.
I have all my medical records here, and sorry.
Not quite so sure.
Okay, we'll wait for you to get over to the microphone. Next person, please. Next person at the mic. Yeah, please. Sure.
My name is Rhonda Bartholomew, and I have 2 questions. Have any of you had an experience with a Lyme patient as we have, where the color in one eye completely disappears? Visually, they're fine every other way, but just the color will come and go. So it's like black and white in one eye. Or know the mechanism behind that?
Our ophthalmologist is gone. Anybody else want to comment on that? Yes, please. Come on over here and use the mic, please.
My name is Dr. Judge. I'm tomorrow's ophthalmologist. And one of the mechanisms involved is if you do suffer with either maculopathy that involves the most central portion of the retina, or with optic neuritis, you will lose color vision. So yes, that can happen in bouts. And demyelination could be involved in that too, as well as fluid behind the retina in the choroid portion. Thank you. You're welcome. The second question, just real quickly, has anybody had experience with thermographies, especially in the gastrointestinal area with children? My child has Lyme, and we work in a practice that has a large number of Lyme patients. And we've seen a couple of situations where we've taken these patients and had thermographies done on their bellies. and nothing else could be documented, that they would be all inflamed. And then they would use them as a research paper, and after each week of their treatment, the redness, the pink area, the hot pink area, they call it, would swell, would decrease down to a small center after about 6 weeks. So we're kind of interested in our area of getting more people aware that thermography can't tell you what disease process is going on, but can tell you there is inflammation going on. So if somebody just, put that little feather in their hat, it might be helpful.
That kind of goes in line with Dr. Squimenti's description earlier. Did you hear what she said? No, I didn't. Could you explain one more time about the need for Dr. Squimenti?
Thermography is a computerized diagnostic tool that they stand in front of the instrument. They don't have anything to eat an hour prior or take any shower, anything to alter the temperature of the body. And then they break it up on the computer in all these different colors, and you can see the liver, the spleen, everything. And if they're inflamed, they'll have different color changes. And it has been extremely helpful in the little ones who complain constantly of abdominal pain, and everybody says it's just, in their head or whatever it is. They can't find any explanation for it. There's something truly inflamed in there.
Well, I'm sure, but I'm going to defer to our gastroenterologist here.
Yeah, you got a mic. Why don't you just hold that mic in your hand and we'll pass that one around.
I think that's wonderful. I never even heard of thermography. I think that's great if you can follow the inflammation. As a gastroenterologist who does procedures on kids, part of the problem I've had is when I go in and I do the actual procedure, what I think looks like inflammation is not what necessarily comes back on my biopsy reports. And if you open up any textbook of gastroenterology, they'll tell you that's normal. The actual appearance is in no way correlated with the biopsy findings of inflammation. So if you have something like a procedure like that, and they can tell you inflammation, I guess, based on heat, and the heat is what represents the different colors, I think that's wonderful. I try and do the procedure because I try and get biopsies to show what kinds of cells are present. For example, if I see eosinophils, that might mean that there's allergy going on, and it may be related to antibiotic use. So I try and go one step further than just there is inflammation, there isn't. I'm trying to find out what the cause of the inflammation is so that I can relate my treatment to the specific cause. If I see plasma cells and lymphocytes, that may mean that it's a chronic infection. If I see white polys, that might mean an acute inflammatory reaction. And I try and tailor my therapy based on the kinds of cells, the cell population. And to find out if my therapy works, sometimes I even go in and rescope a person a second time. And in that particular patient who I did, the healing went away completely in the stomach. That's pretty specific, biopsy-proven healing. But I think that if all you're interested in doing is following that there was inflammation and that it's getting better, non-invasive, doesn't involve anesthesia, I think that's a wonderful test, and thank you for bringing it to our attention.
You're welcome.
Mrs. Hermanson?
Yes. I'm here to ask for help, really.
Put your face closer to the mic.
I'm here to ask for your help in some way. I have gone to a lot of doctors. I live in Jackson Heights, Queens, New York. There is not one doctor who can be recommended. I've been to a lot of them, and they told me I do not have Lyme disease. I was in New York Hospital, Cornell, on 68th Street, New York Avenue, in November of '89. And the doctor was Dr. Bardis, was his name. He said he knew all about Lyme disease. And I was taken by ambulance on first week of, or first Saturday in November, in fact. I was there for 10 days. They did all kinds of tests. And he said, you do not have Lyme disease. I said, what do I have? He said, I don't know.
Okay, well, I think what we can do is find you a doctor. Who lives closest to Jackson Heights here?
Yeah. Well, I'm willing to travel if I can.
All right. We'll find you a doctor. Are you going to be here tomorrow?
No, I'll be going back to Jackson. I just wrote a letter to, I'm a member of the foundation. I just
After you sit down, come over here and give us your name, and we'll find you a doctor that will at least check you out to see if you have it or not.
Thank you.
Thank you. Next. Yes, go ahead.
Hello, I'm Keith Damer from Humboldt, New Jersey. I'd like to raise two issues for discussion, and if I may do them one at a time. The first issue is for Dr. Masters and for Dr. Gubler. I was just listening to Dr. Masters talk this afternoon about the incidence of Lyme disease in the area where he practices in Missouri. And at least from my point of view, and I think many of you, it seems like he presented some strong evidence that there is in fact Lyme disease in his part of the country. And yet, just before his presentation, I was talking with Dr. Gubler from the CDC with respect to the incidence of Lyme disease in Missouri, and he asserted to me that there is no provable evidence that there is Lyme disease in that area of the country. And so what I would like to do is to ask Dr. Gubler to come up and explain his position in the context of Dr. Masters' information.
That's what I get for talking. What I did say to Mr. Dams is that there's no good evidence that Borrelia burgdorferi is in Missouri. And after hearing Dr. Masters' presentation, I don't think anyone can go away with the conclusion that there isn't erythema migrans and that there isn't a Lyme-like illness that occurs in Missouri. I think the proof is, though, there is no good evidence that it's caused by Borrelia burgdorferi yet. That isn't to say that Borrelia burgdorferi may not occur in Missouri. It may well do. It has been isolated from Oklahoma. It's been isolated from several states, Texas, and it probably does occur in Missouri. But on the basis of Dr. Masters' cases, we sent a team to work with Dr. Masters in the summer of 1991. This included entomologists as well as epidemiologists. They did extensive case control studies with Dr. Masters' patients. No question that there's erythema migrans there. We've got the pictures, and Dr. Masters has well-documented cases. The bottom line, though, is that we cannot find Borrelia burgdorferi. We've, with Dr. Masters' help, cultured a number of biopsies from patients. I don't remember the exact number, but probably around 20 in our laboratory. Dr. Masters, I think, sent another series of, correct me if I'm wrong, Dr. Masters, around 75 patients to Dr. Russ Johnson in Minnesota. They're all uniformly negative for Borrelia burgdorferi. He's correct in saying that both the CDC and other laboratories have confirmed serologically, or at least have serologically positive cases from Missouri, but that only means that there is antibody that reacts to Borrelia burgdorferi. We know that most of the tests that we've been using in recent years are very nonspecific. They do cross-react with other organisms. So serologic evidence is not proof of Borrelia burgdorferi. We have subsequently, both in the summer of 1991 and subsequently last summer, tested on the order of 4,000 Amblyomma americanum ticks for Borrelia burgdorferi infection. We have not been able to culture. We have found in approximately 4% of Amblyomma americanum motile spirochetes. But everything that we know and everyone that we can consult, there is no evidence that this is Borrelia burgdorferi. We have not been able to culture it. We spent the better part of a year trying to culture spirochetes from these ticks, and it turned out to be the thing that we were looking at was a pseudospirochete, which actually is the flagellum of a bacillus called Bacillus cereus. We're not sure what the spirochete is in the amblyomma. There's no doubt that it occurs, but as I say, the evidence suggests that it's not Borrelia burgdorferi. So basically, Where we come from at CDC is that there's absolutely no doubt that Dr. Masters is seeing erythema migrans. He's seeing a Lyme-like disease, but the evidence suggests that it's not Borrelia burgdorferi. It doesn't mean that it doesn't occur, doesn't mean that it's not a serious problem, just means that it suggests that it's not caused by Borrelia burgdorferi. And I think that this underscores a problem that we all have. We had the same problem in Georgia in 1989. Georgia reported something like 700 cases of Borrelia burgdorferi in 1989. We questioned it because we had never cultured or seen any evidence of Borrelia burgdorferi either in the enzootic cycle or in the humans in Georgia. We worked with Dr. Oliver and his group. We now know that Borrelia burgdorferi occurs in Georgia. Dr. Oliver has isolated it. He has something like, 16 or 17 isolates now, Jim?
Yeah.
So that there's no question that there's an enzootic cycle going on in Georgia. But with the prevalence of the bug in the ticks, it's quite clear that those 700 cases were not all Lyme disease. They were probably false positive serologic tests because the health laboratory was using an IFA test with too low a cutoff. And so, but these are the kinds of studies that we're here to do, and we'll welcome working with any groups to try and solve these kinds of problems. But where we come from at CDC is that we need to be public health oriented. We need to keep a scientific base for public health, and anecdotal evidence is important, but we as a public health agency need to document it before we can make recommendations.
Dr. Goodler, thank you. We dragged you out and made you
May I respond?
Thank you for rising to the occasion.
This is exactly what I object to. Wait a minute. No, please, give Dr. Goodler deserves respect, but I am required by law to report this as Lyme disease. These are not my criteria. These are their criteria. Now, wait a minute. Clinically, this fits all known parameters and criteria for Lyme disease. I am required by law to report it. I have done my damnedest to document it and assist and cooperate with anybody that wants to find out what they think it might be. Clinically, it fits the criteria for Lyme disease. Now, I am required by law to report it as Lyme disease, which I do, which it is reported, which it is investigated, which it is so confirmed. Then they back off like this, and I am put between the clinical and legal rock of clinical Lyme disease and the CDC hard place of, well, we're just not real sure about that. Well, then they can change the law, they can change their criteria, or they can get off my case. I am not going to have that. Wait a minute. What we have is a look-alike spirochete that bites, that is found in ticks, that bite people, that shows a look-alike spirochete in the ticks, which produces a look-alike lesion that is supposedly pathognomonic for disease, which gives look-alike test results, which gives look-alike clinical syndromes, which gives look-alike serologies, and I have made the unpardonable sin of giving it a look-alike diagnosis.
Well,
clinically, it's Lyme disease. Bacteriologically, maybe it is, maybe it isn't. I don't care. My patients don't care. We want it checked out.
I just have to say one thing, and that's that I think we need to remember that we're treating individuals. We're not treating illnesses. Diseases occur in people. People modify the disease, and people make every case different. And we need to remember that. Go ahead. One more comment, then we're going to move on to some other questions.
I don't want to take a lot of time, but just to respond to Dr. Masters, I think that, first of all, we don't pass the laws that require you to report. That's the states, and it's an organization called Council of State and Territorial Epidemiologists that pass the laws on reporting. We encourage the state epidemiologist of Missouri to go ahead and count these. If Dr. Masters reports them, they need to be reported to us. But, Lyme is not unique here. We deal with diseases every year, many diseases coming into the United States that are clinically compatible that we don't report on the basis of endemicity. I'm a virologist. I've spent many years working on dengue hemorrhagic fever. We every year have coming into this country between 200 and 400 cases of dengue hemorrhagic fever, mainly imported. But we don't call them that. They're clinically compatible. They meet our case definition, but we can't call them dengue hemorrhagic fever because we have good laboratory tests that we can rule it in or out. Most of them turn out to not be, but that's a problem, and I sympathize with Dr. Masters. He is, but please continue to report them. The fact that they're not Lyme disease is a decision based on that the state epidemiologist has to make, not CDC.
Thank you for resolving our problem.
Well, may I say one thing? The absence of the culture is not the absence of disease. Now, it is entirely possible, I think, maybe I'm wrong. If I am, I wish somebody would prove to me that I am so we can end this. I'm getting tired. That because of a different tick and a different microgut flora, there might be different culture requirements, or it might even be a new disease. I frankly don't care. I have asked Dr. Dave Dennis, and I have it in writing. I have presented him with case history, said, okay, you're the doctor, here's the patient. What are you going to diagnose it as, and what are you going to do with it? He's going to call it Lyme disease privately, and he's going to treat it as Lyme disease and encourage me to do so also, because clinically it is. I can give you probably 600 references that Lyme disease is a clinical diagnosis. Well, I'm a clinician, and I made the diagnosis, and I made it damn carefully. And it's not a clinical diagnosis, folks. And that's one of the big problems. I have people in Missouri who see this, and they say, why should I report it? Why should I? Just get in the middle of a controversy? They don't even acknowledge it. They don't back it up. They don't believe the data. They don't want, hey, let's do away with the law. Let's do away with whatever. These patients are sick. These rashes do not arise de novo. These sequelae are real. If it is not caused by B. burgdorferi, if it's caused by B. confusiosis or whatever, I don't care. I don't care. Clinically, it fits the criteria for Lyme disease. Why can't we deal with that?
Anybody else from Missouri? Back of the line, please. Next.
Okay. Thank you. I'm surprised we didn't talk at all about the PCR test. I don't want to stir up any more discussion on this point. I'm also, as a father of a son who has had Lyme disease for over 20 months now and going through a series of relapses and remissions and so forth, I think the real issue here is this kind of brings to head the fact that patients are caught in this crunch between these controversial positions, and insurance companies are adopting it to the detriment of the care of the patients who need treatment. With that aside, let me go to my second question. And by the way, I did mention to Dr. Gruber before I got up here that I was going to involve him a little bit. So I think this is more fun than just asking questions. A little debate here is positive. And the second item was with respect to Dr. Liegner's presentation, and again, some discussion I had with Dr. Gruber. And in that discussion, he told me that what's important is not whether this is Lyme disease or disease X or whatever, but the fact that patients are sick and their doctors are determining clinically that they require treatment, that they're responding positively to treatment, and that they should be receiving insurance benefits for that treatment. And yet, we just heard Dr. Liegner describe a series of cases in which, in fact, in real life, that's not what's happening. And what I would like to know is what the CDC is going to do with respect to helping patients across this country who need the support of the CDC to get this disease solved, treated, and supported.
Anybody want to answer for the CDC?
See, since I'm the only one here from CDC, I'm not sure I can answer Mr. Dam's question. I did tell him that I sit in a town meeting in New Jersey in Monmouth County about 6 months ago and listened to several hundred people. Dr. Drill was there and other people. I came away from that meeting certainly sensitized to the fact that something is happening. There are many people who are sick I personally don't think all of them have Lyme disease, but that's beside the point. I think we respond to treatment, they should be treated, and anything that CDC can do to help stop the insurance, and I told them this 6 months ago in New Jersey, stop the insurance companies from limiting treatment, we would be happy to do it within the constraints that we work, but I'm not sure that CDC can do anything about it.
A little louder, please, and can you tell us who you are? No one else can hear you. You want to use the microphone, please?
I'll repeat it. He's saying that the CDC's actions in New Jersey have assisted the insurance companies in constraining or limiting treatment. Is that right? Yeah.
Study on the negative effects of sepsis time exactly at the time that the state legislature was contemplating a bill to prevent insurance companies from limiting treatment. Can you comment on why that study happened then?
Okay, I'd like to cut this conversation off because I don't think it's really going to go anyplace. I think that it has to do with how we respect the patient in the final analysis. And I think we need to listen to the patients and we have to let them tell us what's wrong. We're not always right. All we can do is the best we can. And I think that when a doctor, a clinician who's taking care of a patient for a long time feels that a patient has one disease, I think it might be detrimental to come in and say, you don't have it. As detrimental as being wrong on the other side.
But let me say that CDC did not know that the New Jersey legislature was considering the bill at that time. We came in when the state health department allowed us to come in. The study was a follow-up to a June study that we carried out there on home instruction for students. And we had no idea that the insurance company was meeting, or that the legislature was considering a bill at that time.
Thank you again.
Could I say something? Jim?
Yes, go ahead.
Paul Lavoie. What I'd like to address for a moment is our polarization. The CDC is not the enemy. In fact, I very much consider the CDC to be our ally. And I would encourage all of you to think along those lines. The enemy is the disease. We're only, 11 years from the discovery of the organism. In terms of medical evolution, that is the evolution of emerging diseases, it's not quite a microsecond, but it might be considered a millisecond. It's a very, very short time to work things out. And if we simply go down the path of trying to find enemies, we'll never get this job done. Let's try to be a little more friendly.
I probably should respond to that, but one of the things that I think we need to bear in mind, and like Dr. Lavoie said, and he's always got a cooler head, is that we are seeking the truth, and it has been a short time. And that is also, the other side of that coin is also why some of us who see what we see, I don't need somebody to tell me what I see, I know what I see, and I know what it ought to fit and what it shouldn't. You know, let's look at the quote conventional wisdom track record on Lyme disease, okay? We thought it was a virus. It wasn't, okay? We thought it was regional. Not to the degree that we thought it was. We thought, well, no deer tick, no Lyme disease. Well, we find out there's not even a deer tick as such. It's not even its own species that they thought it was. Then we thought, well, it's easily cured early and late, and it's not. And you could go on and on and on and on. The track record on the conventional wisdom and dogma is underwhelming. You know, when somebody is telling me 1 year ago, you cannot have the disease because you don't have the Ixodes damini deer tick, 1 year later, the Ixodes damini deer tick doesn't even exist properly, yeah, I'm skeptical. You damn right I am. And I am willing to call it master's disease in Missouri, and I've put that in writing. I'm willing to call it whatever to help these patients. But we've got to get to the truth. We've got to look at it. You can't. Not only do we need help, but we cannot continue to diagnose with dogma. Okay, we need evidence over ego, and we need to take care of our patients over the politics.
You've been very patient. Please, go ahead.
Hi, I'm Laura Sawyer. I'm with the Lyme Disease Coalition in Minnesota. On behalf of Minnesota, I'd like to thank the presenters and the researchers and all of the people who are working in the field of Lyme disease. I think the discussion that we just had underscores the fact that this is an evolving picture, that we know less about this disease than we need to know, and that it's important that we continue to dialogue together respectfully to advance the cause of understanding of Lyme disease. I have a real specific question to the entire panel. It's regarding the role of hormonal influences in the disease, the manifestations and differences in the disease.
What I have started to see, and one of the first questions that I ask a lot of my female patients, when they call me and they're in the middle of their therapy and they say, well, my symptoms are getting horrible, they're really getting bad, what's going on, what am I going to do? One of the first things I ask them is, are you menstruating at the present time? Are you premenstrual or are you ovulating? I do not have any evidence, again, and as a scientist we have to be very careful as to what we say and what we implicate and imply. I do not have any evidence, but what I thought of doing, in fact, I just drew this thing up in the office. What I was going to do was put down a 28-day, day 1 to 28 or day 1 to 30, and assign a number for the woman to try to assess. Number 10 being the best she's ever felt, number 1 being the worst. And try to analyze or see if there's any correlation in the hormones or any hormonal manipulation. I recently had a patient who had really horrible, in fact she has endometriosis. The gynecologist called me and he said, what do you think about me doing some hormonal therapy? I said, it's hard to say, but all I can tell you is that I have seen the patient's symptoms exacerbate during those periods, and that's basically it.
Can I say something on that?
Sure.
I would just like to explain, I was here to ask a question, but I just wanted to explain something that I can tell you. I have a daughter who's 18 years old, and for the past 3 years we have documented during her menstruation she is so sick she can't get out of bed. We know the day before it's time each month because her Lyme disease gets so bad she can't get out of bed. And originally we thought that was just a problem, and then we realized that it was a Lyme disease, but it definitely has affected her, and we have document proof of that.
Thank you. Yeah, it's also been my experience that perimenopausal women do better with estrogen therapy. I don't know what everybody else's experience has been. I see heads bobbing. Yeah.
Dr. Castle, can you repeat that briefly? Did you say postmenopausal women do better with
Perimenopausal, women that are around the menopause, whether it's just before the menopause or going through menopause, do better with estrogen therapy.
Thank you very much.
Go ahead, please.
Hi, good evening. My name is Joe Burke. I represent the American Lyme Disease Alliance. First, I'd like to throw out a couple of things to the doctors, and then I'd like to ask my question. If any of you know me, you know I have a difficult time dealing with a disease called chronic fatigue syndrome. I myself was diagnosed with this illness and found out later that I had Lyme disease, thanks to the fact that my wife had Lyme disease. Other than that, I never had a positive test. Now, I don't know if anyone knows, but approximately 2 to 6 million people in this country are diagnosed with chronic fatigue syndrome. If only 80% of these people found out they had Lyme disease, it would cost the insurance companies a minimum of $80 billion per year. So this is something that the insurance companies do not want to deal with and are going to try their best to keep from the general public. Now, I believe Dr. Coyle is doing some research with regards to Lyme disease becoming chronic fatigue. She said to me chronic fatigue, not chronic fatigue syndrome. My question is, well, first I'd like to say that people with chronic fatigue syndrome, in 90% of the cases, do not get better. These people meander. They're always sick. They're always tired. It's constant. They're not going to get better because in most instances they probably have the Rayburg-Doffer. My question is, how can anyone suggest that Lyme disease is becoming chronic fatigue, whereas if you gave them continued treatment, they would continue to respond, though it might be slow. There is no definitive cutoff for Lyme disease treatment, and people have to think in those terms. We do not have a definitive cure. I see that Stony Brook has this award. Are they saying that these people are post-Lyme syndrome people, or are they saying that they're continuing the treatment and these people are not responding whatsoever?
Who would like to tackle that?
Well, we do indeed have a grant funded by the NIH to look at one of the post-treatment syndromes. These are patients that had documented Lyme disease in various forms, meningitis, EM, arthritis, Bell's palsy. And as most of you should be aware, fatigue is one of the most common symptoms in clinical infections with Lyme disease. In a subset of patients who develop Lyme disease, get antibiotic treatment, the infection persists for prolonged periods of time. We are studying those groups. This is not a treatment trial, in order to get at what the pathogenetic mechanisms of that post-infectious chronic persistent fatigue state might be, with regard to whether it might be a persistent infection with a prior triggering agent, B. burgdorferi, or whether it is an abnormal immune response against the triggering infectious agent, B. burgdorferi. Chronic fatigue syndrome is an increasingly recognized syndrome, not a disease, that may be triggered by multiple infectious agents. For example, hepatitis, brucella, EBV in certain cases, and it is not necessarily true that in those patients with persistent fatigue there is a chronic active infection. As a matter of fact, that's an exclusionary criteria for the CDC definition for chronic fatigue syndrome. We're not involved in any treatment trial. We are involved in a study of a difficult post-Lyme syndrome to try to get at the pathogenesis of that syndrome.
Okay, so you're discounting that. You're saying it's no longer Borrelia burgdorferi.
No, you're not hearing what I'm saying at all. I said that we don't know the pathogenesis. We are looking at the question of persistent infection. We are not blindly plugging these patients into treatments because you really don't know what the pathogenetic basis of the problem is.
And then what was the treatment protocol to begin with?
Okay, we didn't treat these patients necessarily. They received what we considered, what was considered, generally considered adequate treatment of whatever the initial syndrome is. So they are not coming in to be treated by us.
Right.
They are coming in to be studied via spinal fluid analysis, cell analysis, serum analysis, cognitive function, formal testing, formal psychiatric assessment, allergy testing, a whole battery of things to look at whether they do have evidence of persistent infection by our experimental tools and by looking at their immune response to B. burgdorferi compared to control patients, treated Lyme patients that don't have the persisting problem. You see, you're plugged into treatment. That's not the focus of this study. As I'm saying, we're looking at pathogenetic mechanisms. And maybe it will turn out, if we can document that a proportion of these patients are persistently infected, then the next logical step is indeed to enroll them in a controlled treatment study. But that's not the focus of our study because we're starting from square one. We don't know what the pathogenic mechanism is.
I realize what you're trying to do is good, and I'm not trying to give you a hard time or anything. I just have great difficulty with the chronic fatigue syndrome movement.
I would just repeat I would just mention to the audience what I had told you in our private conversation before this started, that it has been documented that you can take cytokines, which are immune system factors, have absolutely nothing to do with an infectious agent, and infuse them intravenously and reproduce fatigue. There's a lot of other symptomatology. Here's a non-infectious agent, simple immune factor that can reproduce fatigue in people. So you don't necessarily have to have an active infection. You may simply need an active immune response. I don't know. That's why we're looking at these patients.
But I just find it troubling because it seems like it's based in the same ideology that Dr. Steer's been talking about.
I don't know why you would possibly say that, though. We're looking in the spinal fluid for evidence of persistent infection with our research tools. We are freezing away CSF for PCR testing. I mean, why would you possibly say that?
Okay,
That's one of the postulates that we're testing.
Right. Okay, and the reason I had questioned it was because the chronic fatigue syndrome movement, specifically the CFIDS Association, has been touting your work as being proof that Lyme disease is turning into a chronic fatigue syndrome. And there seems to be almost an orchestrated movement to make the public believe that this is indeed occurring and these patients do not have Lyme disease anymore. They're just suffering because of post-Lyme syndrome. And I'm not trying to give you a hard time about it, so don't take it
What I
personally.
had in my slide was that we clearly recognize, and I think anybody that deals with a lot of Lyme disease recognizes this, that in some of the patients that get treated and have persisting problems, the predominant complaint is significant fatigue and malaise. Okay? And we're calling that a persisting fatigue problem, not saying this is the chronic fatigue syndrome, okay? But what I'm saying is it can produce a persisting fatigue problem that looks very much like the idiopathic CFS, because we have no idea what causes, and CFS probably has multiple causes.
Okay, thank you.
My name is Deborah Spinella. I'm here representing Congressman Andrews, New Jersey, 1st Congressional District. I myself live in Winslow Township, New Jersey. That's about 45 miles west of here, in a very endemic area. I have Lyme disease diagnosed for 8 years. 3 other members of my family have it. So I'm constantly trying to prod the congressman in the correct direction. The question that I have is, does anyone here, have they developed or are they considering outlining a specific educational or study program for students with Lyme disease or organizing teachers in service programs? I see where there's a slack there.
Kevin, go ahead.
I wonder, would it be possible or proper for me to ask someone in the audience who is actively involved in this question to come forward to talk?
They want to, sure.
Is Dr. Brennan here, and would she like to address this issue?
Thank you, Kim. I am a physician myself, basically trained in primarily emergency medicine, and have done a fair amount of research both at NIH and Memorial Sloan Kettering. I've not been working for 4 years because of my own Lyme disease, and I have a husband who's a surgeon who does not believe Lyme disease exists. I have 4 children who have Lyme disease, one of whom required intravenous Rocephin last year in his sophomore year of high school, was profoundly, essentially incapacitated by Herxheimer reaction, treated by Dr. Wigner, for 6 weeks. After 10 weeks of Rocephin, was basically functional again and was able to go play soccer in a European soccer tournament. He now is conceivably relapsing, and I have dealt with my oldest, who last year was a senior, who graduated from high school by the skin of his teeth. My younger 2 are 15 and 13 respectively. all in high school, the three older in high school, the youngest in middle school. It became clear in dealing with these children that the school system in northern Westchester is really not tuned in to Lyme disease as a problem, either with respect to dealing with students who have Lyme disease and the vagaries thereof. Primarily, I think, as a result of the fact that children who have Lyme disease, as a rule, do not look sick. This 16-year-old boy who was on Rocephin, had a PICC line, went to school, his teachers said, "You're just goofing off, you're gold booking, you're avoiding work." His principal said, "Gee, I saw him in school, he looked great to me." Basically, these children do not look sick, and therefore it's the natural tendency of educators to assume that they are, in fact, gold-bricking or underachieving or what have you. My youngest has an IQ of 140. He has been dubbed a classical underachiever by virtue of his Lyme disease. Obviously, as a result of my own experience, I have, and because I am not working, I have become involved and interested in the neuropsychological aspects of Lyme disease and its relationship to the academic performance and school performance of students who have Lyme disease, as well as the fact that educators, teachers in general, are probably in as good a position as parents or better to recognize some of the early cognitive changes or behavioral changes that children undergo. So I have, in fact, serendipitously almost, again, because I'm not working and I have the luxury of having the time to be able, when my brain is functioning Lyme-wise, the time to devote to discussing it with various groups. I have given some talks at faculty groups regarding the cognitive, academic, neuropsychological aspects. I've worked and beginning to work with a very good neuropsychologist in Westchester County, New York, who has a large volume of Lyme patients. About 3/4 of her practice is Lyme disease, although it's mostly adults who have been referred because they cannot continue to function at work. Basically, I hope to be able to field with this neuropsychologist and hopefully the help of Dr. Fallon and Dr. Ligner, a study of the neuropsychological academic aspects of Lyme disease, particularly as it relates to children and particularly as it relates to their functioning and ability to attend a public school system, which in my own experience has been very problematic. So that's